Okay, so thank you very much, Norbert. Thank you very much, Emilio, and the organizers for inviting me. It's a great pleasure to be here. So in my presentation, I'm going to cover three topics that are related. First, what we know about the current TB, HIV mortality burden and some concerns about its measurement. Second, I'm gonna talk about where that mortality occurs in the TB and HIV cascade of care. And lastly, I'm gonna talk about how we can reach those TB cases that are missed by the health system and that account for a large proportion of the mortality. So this map shows by WHO region the number of people dying from HIV-related causes. We see that the region that accounts for a larger amount of HIV-related deaths is the African region, followed by Southeast Asia, totaling 1 million deaths from HIV-related causes. From that 1 million deaths, almost 40% of them die of tuberculosis. So it's the single most important killer in people living with HIV. Although the co-infection TB-HIV accounts for only 10% of all tuberculosis cases, the co-infection accounts for 25% of the mortality due to tuberculosis. So why is it important to measure mortality in people living with HIV and tuberculosis? First, to assess progress in the NTB and in the fast-track global strategy. So if we have targets about achieving certain thresholds of mortality by 2035, we have to be able to measure mortality as precisely as we can. Curiously enough, the fast-track strategy does not have the hard endpoint of mortality among the main indicators. This has been widely criticized and hopefully reconsidered. It's important to measure mortality to establish health priorities in the countries. Countries want to know where TB and HIV and TB/HIV rank in their health, in the public health problems. It's important to monitor TB/HIV interventions and health programs, and it's also important to monitor the case fatality rate that can alert us about the suboptimal implementation of the standards of care for tuberculosis and HIV. So what are the current methods that we have to measure TB and HIV mortality? So we have vital registration systems, which is a good tool in high-income countries. However, those countries enduring the highest burden of disease, of TB and HIV, the coverage of vital registration system is suboptimal, so it's not a good tool. We also have to make use of other sources of information, such as hospital records. These three references here are about autopsy studies conducted in sub-Saharan Africa, which shows that clinical diagnosis has a high rate of discrepancies of clinical pathological discordant results. So they might not be a very good tool for ascertaining TB diagnosis. We can also use the treatment outcomes from the national tuberculosis programs. The problem is that a lot of people who die during treatment might not die of tuberculosis, and we have some people that are lost to follow-up that might die and are not captured in the information from the NTPs. We also have verbal autopsies, which is the interview that health workers have with the families of the deceased person, asking for signs and symptoms pre-mortem in order to narrow down what is the most likely diagnosis. However, verbal autopsies also have a poor correlation for some infectious diseases, such as tuberculosis, for determining cause of death. So we have the full autopsy, post-mortem examinations, which is the gold standard for ascertaining TB diagnosis. However, they are seldom performed because in low-income countries, there's few pathologists. It's time-consuming, expensive, and they are hardly ever performed outside of reference hospitals and for legal reasons. That's why we make use of modeling to estimate TB mortality estimation. So what are the two institutions that provide global mortality estimates? One is the WHO, who releases annually the Global TB Report, and they stratify data by HIV status. And we also have the estimates released by the Institute of Health Metrics at the University of Washington that under the global burden of disease, they measure a series of conditions, injuries, and diseases, among them TB and TB-HIV mortality. So data from the year 2015 comparing both estimates showed that there's quite a difference in what they believe is the true burden of TB and HIV mortality. While the IHME estimated for 2015 a little over 200,000 deaths, the WHO estimated almost 400,000 deaths attributable to TB HIV. So basically, the IHME estimated almost half of the deaths estimated by WHO. What happens in a country like where I work, in Mozambique, the number of deaths estimated by IHME was 15,000, but the WHO estimates more than double. So this is very important for policymakers and for the tuberculosis program in Mozambique, because they don't really know what is the magnitude of the problem. If we take a look at what are the countries that account for larger differences in estimates by both institutions, we see on the right-hand side Mozambique, Tanzania, Indonesia, South Africa, and Nigeria that account for countries where the estimates are very discordant. This could be due to the different modeling strategies, but also to the data sources that they use. The WHO uses make intensive use of prevalence surveys. For example, IHME also uses verbal autopsies in their estimates that we see could be contentious. So here I present one exciting tool that has been developed in recent years in order to ascertain TB diagnosis. Is the minimally invasive autopsies. It consists of puncturing key organs with autopsy needles, and you get these cylinders of tissue that then is analyzed in the lab, microbiologically and also under the microscope. So these are the organs that are that are punctured during this minimally invasive autopsy that can be done in a decentralized healthcare setting quickly, and is well accepted by the relatives of the people dying in low-income countries. So the CADMIA study compared aimed at validating minimal invasive autopsies in general, and the results for tuberculosis show a sensitivity of 80% to determine tuberculosis as cause of death and a specificity of 100%. You may think that 80% is not a good sensitivity, but it's much better than the clinical diagnosis in these settings. So the take-home messages so far: TB is the main killer among people living with HIV. There's some uncertainty about the global estimates and also at country level. And third, we need better tools to diagnose TB as cause of death. So where does those deaths occur in the cascade of care? Well, we know that not all cases with TB and HIV are tested for TB, only a proportion of them. We know that out of those people tested, only those get diagnosed of TB. Only among those who are diagnosed, a proportion of them get treated, and not all of the ones that get treated are cured. Of course, the cascade of care starts before the disease occurs, so we could intervene among those who are exposed and preventing them from being infected, and from those who are infected, preventing them from developing disease. But this side of the cascade has been covered in the previous session, so I'm going to focus among people who already, people living with HIV who already have TB. Those of them who do not get cured, of course, are associated with a high mortality. So this is the current cascade of care at scale, with what we believe are pretty close numbers to reality. And the size of the boxes, we estimated them using information from the WHO, from other systematic reviews, and from papers on diagnostics in high-burden HIV and TB settings. So this is where mortality would occur in the cascade of care. We see that most of the mortality concentrates in people who are not diagnosed of tuberculosis, and they account for almost 400,000 deaths according to the WHO. Of course, those who do not die are supposed to remain alive after 1 year. So now let's look at different scenarios to see what would happen if we try to intervene at each of the different steps of the cascade of care. So let's think about one scenario where we would achieve an 100% treatment effectiveness and 100% adherence. What would happen to the total number of deaths? So no one would die after being treated, and the deaths would occur before in the cascade of care. So we would avert around 14% of the current deaths. Second scenario, let's imagine that we can prevent pretreatment loss to follow up from happening. So all patients who are diagnosed of TB are treated correctly. So we would still have a lot of deaths, and this intervention would prevent from 11% of the deaths from occurring. Let's look at the third scenario. In case we have a full sensitivity of TB diagnostic tools and diagnostic procedures, what would happen? All people with HIV and TB who are tested would be properly diagnosed of TB. We would still have deaths before and after in the cascade of care, and we would avoid only 3% of deaths. So this already is supported by some of the data of the expert studies, of the LAM studies, that despite having much better sensitivity, they haven't shown impact on death. Let's imagine a fourth scenario where we have 100% access to testing with the other tools working in the same way as they have been. We would avoid around 43% of the current deaths. So the highest impact on mortality would be achieved if we get 100% access to TB testing, or we increase access to TB testing among people living with HIV. So how do we reach those people with HIV who have TB but do not get tested? Well, first, we have to expand and integrate TB and HIV screening services. I think the one-stop model that has been implemented at various degrees of implementation has shown good results. I know Professor Alison Grant is going to expand on this. And we also have to scale up active case finding strategies. The WHO recommends, as a strong recommendation, that people living with HIV should be systematically screened for active TB at each visit to the health facility. So this is partially done, but what is the problem? That perhaps we don't have the right diagnostic tools. Expert cannot be done to every single patient at their visits at the HIV clinic, and perhaps patients do not come, HIV and TB patients might not come to the health facilities, so perhaps we have to go to the community. So a final comment about triage testing. The WHO released a couple of years ago a document about high-priority target product profiles for HIV, and they included among them a triage test, a test that could be implemented at point of care, that is simple, low cost, and can be used at the first contact with health providers. And the minimum required sensitivity would be of 90% and specificity of 70%. There are several candidates that have been postulated to work or potentially work as triage testing, and I truly believe that they need further clinical validation. Among those candidates are procalcitonin, IP10, C-reactive protein, hemoglobin, etc. I'm just going to give an example of C-reactive protein that has been recently published. It's still in press. If you see in this graph, in the left-hand side, we see those people living with HIV with less than 200 CD4 counts, those who are more likely to die. And when we compare to symptom screening, which is the screening test or the triage test that we mostly use, we see that the sensitivity is higher than for symptom screening, and the specificity is considerably higher than symptom screening for TB. This will help us to rule out patients and identify those who would need further diagnostic workup, perhaps with more expensive tools such as expert or others. So in summary, tuberculosis is the single most important cause of death among people living with HIV, but improved TB and HIV mortality burden assessments are needed. Greater impact on mortality will be achieved with increased access to healthcare, reaching the missing cases to increase access to testing, and a scale-up of active case-finding strategies and development of cheap and simple triage tests might ultimately contribute to reduction of TB and HIV mortality. I want to thank my team who are actually working in the field while I'm here speaking before you, and a special thanks to Professor Frank Kovalens for your support and your guidance. Thank you very much.
Thank you.